welcome, welcome. Thank you so much for taking the time on a very valuable Friday night to come. We've got several groups of people who are here, and we've got students from Georgetown University Medical School. We have students from George Washington University Medical School, and we have students from about 25 other medical schools throughout the country, and 3 students from Nigeria. Now, these other around the country students and the Nigerian students are participating in a 2.5-day conference for the Benjamin Rush Institute, which is one of the sponsors of this debate. I'm Beth Haynes. I'm the executive director of the Benjamin Rush Institute. I wanted to give you just a brief idea for those of you from Georgetown and George Washington University or the community that may not be familiar with who we are and what we do. First off, Benjamin Rush was one of 5 physicians who signed the Declaration of Independence. We have him as our figurehead because now I think, as much as during the early time of our country, physicians need to be thinking about more than just their patients in their offices. We also need to be involved with our communities and thinking about politics, because no longer can we avoid politics. It's going to be a huge part of how we practice medicine, and whether you like it or not, that's the truth. So in order to be the leaders that I know you're all capable of being, it's a good idea to be informed. Being informed doesn't mean listening to the echo chamber. It means trying to gather information from as many sources as you can that you feel are trustworthy and respectable. And then sharing those different points of view and the information that you get with others, so that together we sharpen our own thinking, we increase our own knowledge bases and those of the people who both agree and disagree with us, so that together as physicians we can be the most effective advocates for our profession and for our patients. It's important to care. It's just as important to care effectively and pay attention to how the policies that we propose end up actually playing out in the real world. So that's what Benjamin Rush does. We put together debates like tonight on a wide variety of topics on medical ethics issues, most of which Benjamin Rush does not have an official stance, but also on policy issues. And for the policy issues, we do have a bias. We are biased towards voluntary participation in any kind of economic or civil interaction, which means that we really support maximizing solution finding through civil society, which includes businesses and volunteer organizations, and minimizing how much we have to rely on government. We think this gets a better solution. So that up front is our open bias. Now that said, our thinking is better when we engage our colleagues who disagree with us. And tonight, just like if any of you, how many of you guys ever participated in sports? The best games I ever played are actually ones I lost, because that team was better than me, and they pushed me to play better than I ever would have played if I had been playing against someone who wasn't that good. And that's the same way we're going to improve the dialogue and our own understanding of all these very complex issues. So we gathered here today as colleagues who care about our patients, who care about our profession, and we want to find workable solutions for our most vulnerable patients. But we disagree about how to get there. So that's what this debate is about, helping each other understand the pros and cons of all the alternatives that are out there, and helping you understand those to be able to become the real physician leaders that you're going to need to be in this very politicized medical atmosphere these days. So I would like to introduce Jake, who will introduce our moderator, who will introduce the debaters. So put up with us.
Second year.
Jake is a second year, rising to third year. Have you taken your step?
I have.
So he's so close. He's so close. Hey! And he has been running the George Washington University chapter of Benjamin Rush. We also have had very significant participation with the Georgetown students as well. But this is George Washington University, so he gets to be the introducer.
Thank you, Beth. And thank you, everyone, for coming. I know DC is kind of a crazy city. I got to experience some of that traffic today as well. So thank you for making it here on time. And it looks like we have a phenomenal crowd for today's debate. So I'm excited. Without further ado, though, I don't want to, belabor any more and take any more time in the debate. So I want to introduce our moderator, some of the small snapshots of many of the accomplishments he's been able to have. So our moderator for today is Dr. Rodney Whitlock, who's an adjunct professor here at GW's Graduate School of Political Management. He completed his doctorate in political science in March of 1998. His past accomplishments include promoting the Patient's Bill of Rights, working on the Children's Health Insurance Program Reauthorization Act, the Medicaid provisions of the Deficit Reduction Act of 2005, and the Tax Relief and Healthcare Act of 2006. Leighton 2010, he became the acting health policy director for Senator Grassley and shepherded the Medicare and Medicaid Extenders Act of 2010 into law during his brief tenure. He remains health policy director for Senator Grassley. Rodney also teaches at the George Washington University in both the Department of Health Policy and the Graduate School of Political Management. We are lucky to have him for this debate and also at our school, so please welcome Dr. Whitlock.
Thank you all very much. First, just a minor correction. I retired or escaped or got paroled from the Hill in December, and so I'm now on the outside as Vice President of Health Policy at ML Strategies here in Washington. So first, greetings and welcome here to the George Washington University, home of the 2016 NIT Champion Colonials. I've been working here for 16 years. You can't miss an opportunity like that to promote it when it happens. So thank you all for being here tonight. So we'll begin here tonight. I'm going to introduce our debaters for the evening, talk a little bit about format, and then we'll launch into this. Let's see. To my left-ish over here on the affirmative side, we have Dr. Jules Madrigal. Dr. Madrigal is a member of BRI's Board of Directors and runs a successful direct pay practice in Marble Falls, Texas. She's featured on the documentary Wait Till It's Free. Says Dr. Madrigal, I had a practice with little government restrictions for the last 12 years. I've never taken third-party insurance nor Medicaid and not taken Medicare for 8 years. I work very hard to keep my practice and my patients from intervening government influences and thereby keeping the relationship between the patient and the physician sincere. The affirmative side. To her left is David Hogberg. Mr. Hogberg is a former healthcare policy analyst for the National Center for Public Policy Research. Previously, Mr. Hogberg was a Washington correspondent for Investors Business Daily, specializing in his coverage of healthcare and Medicare. And prior to IBD, he worked as a policy analyst studying healthcare and other issues for various think tanks, including the National Center for Public Policy Research and for the Office of Representative Jeff Fortenberry. Mr. Hogberg holds a PhD in political science from the University of Iowa, and he's the author of the book Medicare's Victims: How the United States Government's Largest Healthcare Program Harms Patients and Impairs Physicians. Mr. Hogberg. All right, to my direct right is, on the opposition side, Troy Russell, MD and MPH. Dr. Russell is author of various books and chapters and peer-reviewed articles found in Neuroimage, wow, that's a tough one. Archives of Clinical Neuropsychology and American Family Physician. with his current research and health policy interests centering on providing low-cost, accessible, and high-quality primary care to medically underserved communities through the patient-centered medical home and direct primary care models. And finally, Leighton Koo, PhD, MPH. Dr. Koo is a professor of health policy and management at the Milken Institute of Public Health at George Washington University here. His career has been built around the effort to understand and improve access to affordable health care for vulnerable populations. He directs the Multidisciplinary Center for Health Policy Research, which includes over 20 faculty and 50 staff, and is also on the executive board of the District of Columbia's Health Benefits Exchange Authority, and has helped establish and develop the state-based insurance exchange that serves D.C. residents and employees, as well as members of Congress. So, yeah, and the president. Ooh, okay. So we'll walk through tonight, all right? So since 1965, it has been intentional public policy in America to provide health care coverage for the neediest among us, the poorest among us. But how that coverage is achieved and what means provide the highest quality in is still a subject of debate 5 decades later and the subject of our conversation tonight. So this is how we proceed as a matter of format. Okay? We'll begin with Dr. Madrigal, who will open for 5 minutes. Then Dr. Russell will rebut for 7. Dr. Hogberg will then have 7 minutes. Dr. Koo will then follow up with his 7 minutes. And then we close to Dr. Madrigal with 2 to end. Then it comes back to me as moderator, and I will stimulate conversation, one hopes, for 10 minutes. And then after that, we turn it over to you. Now, when it comes to you, we're going to ask you to focus particularly on brevity and actually asking a question. Now, as a former Senate staffer, I can tell you right now, I can smell a filibuster coming from a long way away. So don't think you're getting that past me now. All right? And also, I'd like to make an especially important plea, even in 2016, for civility. In as much as possible, we would like to keep the civility of our proceedings anything above what we consider our current political approach to civility. So, with that, and making sure my timers are ready, then we will begin with Dr. Madrigal.
Okay, so we would affirm that care for the poor is best provided by charity care and free markets. First off, how many of you all have volunteered in medicine? Okay, right there. So that's what I think, and that's what we think, is that people want to volunteer. Doctors and people who want to become doctors want to take care of other people. That's the whole reason we go into medicine. We like taking care of people. We don't like doing paperwork. We don't like being told what we have to do. We like actually taking care of people. Systems don't care. Governments don't care. Individuals in those systems can care, but individuals are what actually gives care to each other and what actually cares about one another. That's the biggest thing that people have to remember. When in a system, systems are maintained by people being identified and put into certain boxes. When you're taking care of somebody in charity care or even free market medicine, you're taking care of just that person. It's individuals. In my practice, my most rapidly growing segment of people are people who have Obamacare and don't feel like they're getting good care. These are people who before either had no insurance or had private insurance, and now they have cheaper care, but they don't feel like they're getting the same type of care. When you talk to doctors, a lot of doctors don't like to take Medicaid, for example. They feel that they don't actually get reimbursed for the amount that they're owed, and they would actually rather do it for free. Because the people just want to care about each other. Lots of doctors say the amount of reimbursement isn't worth the amount of paperwork, and I just want to take care of people. The other thing is there's a big barrier to care for a lot of these people. A lot of these people who need care, and the poor who aren't getting care are people who aren't good at filling out forms. They're people who aren't good at going online. They're people who don't know what their assets are. I don't know if you guys have done your taxes yet, but my son just did his taxes for the first time, and he was like, this can't be true. This can't be this hard. Well, if you're a patient who has very limited resources, it's very hard to sign up for Medicaid. You have to have some help. If you're a patient who doesn't speak English and you're in this country, it's really, really hard to sign up, and you might be scared to sign up. If you're a patient who has psychiatric issues, it's also really, really hard to find the forms you need to fill out and find care. Charity Care, on the other hand, is available at a lot of doctors' offices and a lot of different places throughout the nation. Every doctor that I've talked to does some form of charity care. Albeit some people said, I take Medicaid, that's charity care. It's really not. It shouldn't be. You should actually be able to see patients and take care of them. Dr. Leedekerken is a doctor in New Jersey, and she has the Rupe Foundation, and she has a clinic that takes care of people for free that doctors rotate through, and they see people for an average of $13 each. Everybody can afford $13 each. My clinic, I see people all the time who are indigent, who don't have any means. Sometimes we see them for free, sometimes we see them for 12 eggs. And it works because people in medicine want to take care of one another. As far as Medicaid, on the other hand, I had a patient on Thursday who came in, who just got out of the hospital on Medicaid. She has cancer and she had a really bad pneumonia. Her allocation for medications had just run out. So she came to the office to see if we could figure out a way to get her the antibiotics she needed outpatient, which we were able to do. So a lot of times people who actually are getting Medicaid aren't really getting free care. And there's a dynamic that goes on between the providers and the patient. The patients feel like they're not getting the best care because they're not contributing to it. And the doctors feel like the patients aren't a part of the health care that they're receiving because they're not vested in it. In my patient population, the patients that don't pay, don't do well. The patients that pay something are the patients that are the most compliant patients. So we feel that care through the free market system or through charity is the best way for poor people to get care.
Thank you, Dr. Madrigal. Dr. Russell, to you for 7 minutes, please, sir.
Okay, we have it on. So I want to reframe this debate. I think oftentimes we talk about that government is trying to encroach, it's trying to take over. In fact, it's the reverse. There's deficiencies in the market, there's holes that aren't being filled. So those that are falling into those gaps need to be taken care of as a moral obligation, as well as individual physicians, as Dr. Madrigal mentioned, have a sense of duty, whether you subscribe to the Hippocratic Oath or just a sense of other form of principles. Most people are going to agree, taking care of the underserved is a top priority. But we need to understand that comparing a cash-based practice, a fee-for-service model, is not the same as comparing a direct primary care or other form, the more popular version of cash pay. So in the form of direct pay, you pay every single visit you go. That could be $100, could be $200, depending on whether you consider yourself a physician of the people or a physician of the CEOs. So your prices are going to change whether you're trying to tailor to one group or the other. It sounds like Dr. Madrigal has chosen of the people. She's often described practicing cowboy medicine, which is to her practicing to those with spurs, the teachers and the preachers. However, there's another form of cowboy medicine. I did my medical school training in Texas that takes a different connotation. That cowboy medicine takes on the outlier, the person kind of going beyond what the evidence shows to be effective. So we don't have guidelines, we don't have protocols because we want to make everyone in a rigid box. They are simply guidelines. However, those that go out and practice in their own form produce more cost, they hurt the patient financially, and also have worse outcomes. And in actuality, the reason we have these protocols and these guidelines that exist, including choosing wisely and all the other forms of U.S. Preventative Task Force recommendations, are because of cowboy medicine. Individuals going out, practicing individual medicine, hurting patients, and driving up the cost of healthcare. So we need to reframe the debate and understand what came first and why we have what we have now. In addition, we need to make comparisons directly. Medicaid by itself improves outcomes, accessibility to physicians, and lifespan, mortality rates, compared to uninsured. Medicaid with a federally qualified health center, a community health center devised to provide care to the underserved and those with public insurance, provides better outcomes, increased accessibility at a lower out-of-pocket cost than in a free cash-based or in a private market, in a private insurance. When made direct comparisons and ambulatory measures, FQHCs, the federally qualified health centers, beat them across the board, and when they didn't, they were at least equal. In addition, cash-based practices, direct primary care practices, do not use traditional measures and don't track their information. There's been very few peer-reviewed journal articles that really describe the outcomes, the cost, the demographics, and who they are actually working with. The vast majority is anecdotal, if it's even on their website. So if we're going to make a comparison, we need to compare apples to apples. The government, for all that is bad that can happen in government, at least one of the good things is that it does mandate that it's tracking where the public money is going. So that if the measures don't measure up and the health outcomes aren't measuring up, then we can change that program in theory. In comparison to not knowing anything about the outcomes. For example, PSA for screening for prostate cancer. The guidelines for mammogram screening for, there's 3 very famous ones that we really are kind of balancing out right now. In addition, clinical breast exams. All these different tests that have been shown to be ineffective, increased costs, increased anxiety with patients, and ultimately do not provide the outcomes we desire, have been deemed irrelevant and should not be used in clinical practice. Not because we're trying to control individual physicians. Instead, we're attempting to improve quality and reduce cost. So the ultimate point, I think the last one I wanted to really hit on was the concept of volunteering. It's unreliable. All of you that are out there that rose your hand to want to volunteer, we all have good intentions and we're all here attempting to provide care for the underserved and the poor. However, we can't rely on an underserved, inadequate system of free clinics, inadequate system of private physicians who limit the amount of Medicaid and uninsured patients because it hurts their bottom line. They care for those patients and they want to make the best with the time they have in their clinic. But they've been shown that even prior to the Affordable Care Act, that a lot of these private physicians kept their uninsured patients not because they were new uninsured patients, but instead were ones that became unemployed, lost their insurance, and the physician kept them on to make sure that they had that patient on board once they got their insurance again. So it was more of a business decision as opposed to a volunteerism. And volunteerism among physicians has dramatically declined over the last decade. Some would say because of the pay cuts, and you can't take that hit to spend the extra time. But I would rather we spend dedicated resources on ensuring care instead of relying on someone who might not show up to the free clinic.
Thank you very much, Dr. Russell. We turn to you, Mr. Hogberg.
Thank you. I want to start by thanking the Benjamin Rush Institute for hosting this debate and Dr. Whitlock for moderating it. I'd also like to thank the audience for taking the time to attend on a Friday evening, something that is all the more a sacrifice when you consider that this is only the second weekend that Batman versus Superman has been out in theaters. So I know you're making a considerable sacrifice to get here. Dr. Russell talks about dedicating resources. And making sure, they're dedicated to the right, where they're needed. The problem with Medicaid is it has to pass through, government, through Congress. And there's all sorts of interests that are going to be competing for that money, for those resources, feeding at the trough, so to speak, in Congress. Let's look at some of the numbers here. From 1970 to 2014, the federal and state governments spent over $6.9 trillion of taxpayer dollars on Medicaid. And what exactly have we gotten for that money? I suggest to you not nearly what we should have unless you consider lining the pockets of politically powerful interest groups a good outcome. We know that Medicaid beneficiaries make extensive use of hospital emergency rooms, and as we've recently learned, many of those people are there not just to try to get free primary care, but because in fact they do have serious health problems. And I suspect one reason they likely end up in the ER is that finding physicians who treat Medicaid patients is quite difficult. Because of Medicaid's low reimbursement rates, 33% of primary care physicians, including 1 in 5 pediatricians, do not see new Medicaid patients. About 28% of specialists also refuse to see new Medicaid patients. A study from the University of Pennsylvania, for instance, found that about 2/3 of children on Medicaid with serious health conditions like diabetes or seizures were unable to get an appointment with a specialist. Now, what about their health outcomes for people on Medicaid? Well, the best study we have on that, the one that had the least amount of bias, is probably one that many of you know, known as the Oregon experiment, where Oregon opened up its Medicaid rolls to about 30,000 people who would be selected via lottery, because there was roughly, I think, 90,000 people who were actually on the waiting list. And researchers realized that you had kind of a natural experiment here where they could track the new people on Medicaid and the people who remained uninsured and look at the results. And after the second-year results released, the researchers found that Medicaid coverage had no positive results on hypertension, high cholesterol, or what's known as hemoglobin A1C, which is an important test for diabetes. Other than a decline in self-reported depression, the Oregon experiment found no improvement in health among Medicaid recipients compared to those who were uninsured. So the best study we have, it appears, shows that Medicare provides very little health benefit for its beneficiaries. So why does Medicaid produce such poor results for its beneficiaries? The answer, as I alluded to earlier, is that Medicaid is a government program, which means that it's under the control of politicians. Most politicians want to get reelected, and that's going to have a substantial impact on healthcare policy. Groups that have political clout, by which I mean, they can influence a politician's reelection chances, are more likely to get good treatment under government-run healthcare systems. Groups that lack such clout are more likely to be neglected by politicians and receive inferior care. Medicaid beneficiaries, who are usually poor and often single women, vote at some of the lowest rates of any groups in our society. Nor do they have the money to lobby or contribute to political campaigns. In short, they lack political clout, and as a result, politicians have little incentive to improve Medicaid for its beneficiaries. So who does benefit from the Medicaid system? Well, first of all, state governments do. For every dollar they spend on Medicaid, the federal government matches it, sometimes more. This comes in particularly handy during when states face a budget crunch. During a budget crisis, states will increase taxes on providers like hospitals and nursing homes and use that money to extract more money out of the federal government. Then they will turn around and use the matching funds from the feds to reimburse the providers through higher reimbursement rates. And then they will siphon off some of the tax revenue that they got from the providers to fill in other holes in their budget. Hospitals, I would argue, also benefit. Roughly about 30% of hospitals make money off of Medicaid. Those hospitals that lose money can use the losses to reduce their tax burden. Insurance companies that offer Medicaid managed care plans benefit as well. They've made money on Medicaid for years, and under Obamacare's Medicaid expansion, they may be seeing a windfall. The 5 biggest insurers in the U.S. saw some of their biggest profits ever from their Medicaid lines of business in the last quarter of 2015. Finally, elderly people who are middle class or even affluent and who need long-term care at home or in a nursing home benefit. Medicaid is one of the biggest payers of long-term care. And while people needing long-term care are supposed to qualify for Medicaid only when their assets are almost depleted, there are indeed many clever ways to hide and spend down those assets so that on paper, middle class and affluent people actually can qualify for Medicaid. Indeed, an entire legal industry, often referred to as quote-unquote Medicaid planning, has sprung up over the last few decades that specializes in helping middle class and affluent seniors find legal ways to hide assets so that Medicaid will pick up their long-term care bills. These are, in fact, the groups that have political clout, that vote at high rates, that can afford to lobby and donate money to campaigns. Ultimately, the benefits of a program that is ostensibly for the poor too often don't go to the poor, but to wealthier groups that have the ability to influence the political system. And let me leave you with one other undesirable effect, going back to the Zarephath Health Center that Dr. Madrigal talked about. And what I'm talking about here is the likelihood that Medicaid spending has crowded out private charity for health care. An extensive economic literature shows that government social spending crowds out private spending on charity, most likely because people feel less obligation to give when they think their tax dollars are already spent on social programs. As a result of this crowding out, we probably have far fewer Zarephath health clinics than we should. Thank you.
All right. Thank you, Mr. Hogberg. And Dr. Koo, you have 7 minutes on the on your side.
Thank you very much, Dr. Whitlock, and thanks to members of both the affirmative and the negative side. So I want to start out by acknowledging that Medicaid is not all that it should be, nor is Medicare, nor frankly is medicine. In general, you know, there are deficiencies everywhere, and I accept that. One of my favorite studies was a study that was done about the level at which appropriate medical care was done within the American medical system in general. This was done maybe 7 years ago by researchers at RAND and a number of others, and basically said the quality of care in Medicaid, the extent to which physicians in Medicaid were providing care that was viewed as being appropriate, was at around 55%. Pretty miserable. On the other hand, I will note that they also found that the quality of care provided by private insurance was about 55%. The quality of care provided to uninsured patients or Medicare patients was about 55%. So the whole system still needs deficiencies and improvements, and hopefully you as future practitioners will be doing a better job. To the extent whether you're doing it on your own on a voluntary system, whether you're doing it in a community health center, whether you're doing it in a hospital, I hope you will all try to do those things that lead to a better system. And it's worth remembering that in fact, under both Medicaid and Medicare, it's not as though we are training doctors to be mindless drones. Generally speaking, the care is provided through a private system. The FQHCs that Dr. Russell talked about are nonprofit systems. Most of the care that's going on in hospitals are nonprofit systems. Most of the care that's being provided otherwise is through the private system. It is not as though the government is forcing people to do certain specific tests or not. There are guidelines that are set up, and sometimes they're associated with payment systems. But by and large, there is great trust in the discretion of the physician to provide good care that's appropriate for their patients. And frankly, if you have one system where there's a payment incentive to do something that's not right, and that's not right for your patient, I hope that you make the right choice for your patient. And I think that's in fact what the expectation is of the medical care system. Let me deal with some of the sort of assertions that have been made by my counterparts that in fact the research says aren't right. One is the notion that charity care can really sort of be this wonderful system. So we've done estimates in the past of how much charity care is there in the US. So just before health reform, the estimates were that there were about $90 billion worth of what's called uncompensated care. So that's the combination of charity care and bad debt care. That is situations where it's not as though the hospital or our doctor didn't expect to get paid, they just weren't paid. So that was around $90 billion in the US. In fact, of that, about half ultimately got reimbursed by government programs like Medicaid or Medicare DSH or the Community Health Center program. So half of that got reimbursed. Of the remainder of the care, about 60% was provided in hospitals, about 20% by community health centers, and about 20% by physicians. So the value of what I might call charity care, truly voluntary care provided to uninsured or poor patients, is around maybe $25 to $30 billion a year. That's a lot of money. On the other hand, the total cost of the healthcare system in the US is $3 trillion. That is, the value of charity care in the US is roughly equivalent to 1% of the total volume of medical expenditures in the US. By contrast, Medicaid these days is running around $650 billion a year. 500 of that is for medical care, around $150 billion for long-term care. The net effect is, I think charity care is wonderful. I wish there was more. As Dr. Russell said, sadly, it has been declining over time. The notion that charity care can substitute for the government-funded care for poor people or for old people is just ludicrous. It's preposterous. It is a wonderful thing when it's provided. The notion that it can do it all will never happen. If we move to a system like that, I've got news. Poor people won't be able to go to the doctors. Elderly people won't be able to go to the doctor either. There's going to be horrible problems. Dr. Madrigal asserted that $13 a visit was perfectly reasonable. Everyone has $13. Now, what she's forgetting is that poor people are by definition poor. So in Medicaid, the average patient has incomes well below the poverty level. We've done research about how much they can afford to care. And so we found that amounts that seem so minuscule, asking low-income patients to provide 2% of their income to pay for monthly premiums for health insurance, and that's about $50 a month for a family of 3. This, to most of us, sounds pretty affordable. What happens when you do that is, in fact, you find participation rates fall by half, because half of the people don't think they can afford even that much for care. So the proposition that everyone has $13 in their pocket to pay for a doctor's visit, I'm sad to say the evidence doesn't show that's true. The evidence suggests that in many cases, very slight differences in co-payments and premiums have enormous influence on the ability of poor people to get access to care. So, we do have a system. Some of these systems work. So community health centers, I'm a huge fan of them. I've done research that basically suggests that when low-income people can get care through community health centers, because of this, they get better preventive and primary care. This actually ends up meaning that compared to statistically controlled equivalent low-income patients, they basically save about 25% of their medical expenditures a year. Medicaid is less expensive than the private system. It's about 30% less expensive. The amount that the patient has to pay out of pockets is about 90% less expensive, making it accessible for people. So do we have these government systems for reasons? Yes. They didn't used to exist, and that was why they were created in 1965 in Medicaid and Medicare, and why they've been expanded. The access works, the quality of care is improved, so it's not perfect. I admit that. But I got news, we live in a world of imperfection, and without assistance like this, poor people, simply speaking, and elderly people won't have access to care. Thanks.
Thank you, Dr. Q. Dr. Madrigal, 2 minutes to you in rebuttal.
Okay, a few points to make. First off, when I say I do cowboy medicine, I'm talking about taking care of people who wear spurs, not disregarding evidence-based medicine. Absolutely, I do evidence-based medicine, and I do exactly what they're teaching you to do. I read every night. and keep up to date. Secondly, on $13 per visit, I'm not talking about the poor people paying $13 a visit. I'm talking about the community paying for that. I don't think that's too much to ask. At the Rupe Foundation, they actually send out a Christmas letter asking the community to give, and every year they get more than enough money from their community to pay that $13 a patient. So, and then finally, I'd also like to make the point about just free markets in general and what they've done for the poor. When we get government out of it and we let enterprise take over, if you think in the past 50 years, the poor now have more room than people in Europe have to live in. They have air conditioning. Most people have air conditioning. Most poor people have ample food supply. Most poor people have cable TV. I don't have cable. Most poor people have cell phones. So when we let the free market work, it works. When we depend on the government and rely on the government, it doesn't work as well because there's way more barriers to put up for people to get the access, and for people don't want to participate in that as physicians, for example. But when we let the entrepreneurs work and the free market work, there's ways around this. And I feel like in this country, we have a lot of very generous people when we have that are more than happy to help one another. And we also have very innovative people. And if we let that work and get the government out and quit meddling in our business, it works a lot better. The last thing I'd like to say is you said that there's great trust in government giving physicians discretion. I don't think there is. I don't think very many physicians feel great trust for the government giving them discretion. Thank you.
Thank you, Dr. Madrigal. Okay, so this being America, we have to keep score. You know how it is. You know, we need winners and losers in everything we do, right? So we're going to ask you to participate in scoring tonight. And our exercise for you is this. You walked in here, you may have had a belief in what you thought was the right answer to this question, okay? Or you may not have been completely decided. So what we're going to ask you in about 30 minutes after we have some interchanges between us and you all and our panelists is to, on your honor, answer this question. Did your opinion change? Did you move from one side to the other, or did you move from undecided into more of the affirmative or the opposition? So we'll ask you to think about this as we have those exchanges. But tonight, when we're done, we would like to press that to you to help us decide who's right. So as the moderator, I get to go first with a question for the panelists. And I'm going to pose a question to both sides that I think is important for understanding some of the differences to the subtleties within this question. Okay? And I'm going to phrase it like this, and I will ask the affirmative side to approach it first and then the opposition second. There's a patient in exam room 3. You walk in the room and you close the door. Does the quality of care provided in that room vary based on the payment system used to pay for the care being provided? And I think this is essential to this debate because we have to decide what it is exactly we are debating. Is it which payment system is best for providing quality health care? Or is it which payment system induces providers to vary the quality of health care they provide? Because the difference is not trivial.
Honestly, my answer is probably going to be the opposite of what you think. Because when patients have insurance, it actually limits me. If somebody has insurance, I have to make it fit what the insurers want to get the test that I want. I particularly have to on medicine. A lot of times to get the medicine I want, they have to fail 2 or 3 other medicines before I can prescribe the one I want. So honestly, when people don't have insurance, it gives me a lot more freedom. I have to use very good discretion because the money that they're paying is coming out of their pocket, so I have to be careful what I choose, but it gives me a lot more freedom for the patient and I to decide what they actually need and what's going to work best for them.
And to the opposition.
You want to
Okay. First off, I think we need to decouple the fact that insurance equals access. I think in reality, you are more likely to see the doctor if you have insurance. However, having insurance does not guarantee you will see the doctor. So we need to get rid of this idea that somehow having a membership card to an insurance company somehow guarantees that you are going to get the care you want or need. So, and if you look at the different plans, and if you've been on any of those plans, you will know what I'm talking about. So there's multiple scenarios in which both sides can make the case that they can, I guess, break away from the incentives of providing good care, a 30-minute visit for someone who's insured, and someone who's uninsured, a 5-minute in and out, because that's lost time. You could be seeing another patient, making you income for your practice. So there's an interesting clinic or series of clinics in Seattle called Q-Liance. What they've done is they have a fixed fee, monthly fee, a bundled payment, that you have 3 separate types of people who can pay into it: an individual, the employer, or Medicaid. So it doesn't matter who the payer is, they make that monthly fee, and they get incredible access, either the same day or the next day appointments. They pay nothing out of pocket as far as copays. They've made 20% reductions, not reductions in the growth, but actual reductions in cost. Reducing ED visits, reducing specialist care, reducing advanced imaging. So it proves the point that it's access to primary care, good, comprehensive primary care, that really is going to drive down the cost of medicine, not necessarily all the gimmicks that we have along the way. That's why ACOs, bundled payments, are really kind of on the front of, well, is this going to work or not? Because fee-for-service right now is not working, especially if you've got out-of-pocket costs that are going to, if you got to make a comparison between paying for rent or paying for your colonoscopy, most people in my practice who I work with day in, day out, they tend to choose, and this is anecdotal, but they tend to choose paying rent.
Thank you, Dr. Russell.
Can I add a comment?
I think I'm going to have to limit you on time with where we go here, but I was actually supposed to limit you 60 seconds here, in fact. So forgive me. You can kick me under the table later. The free market operates under the pressure of a profit motive. Okay, just ask the folks who used to work at Borders, Linens and things, Circuit City, Plymouth, Mercury, Oldsmobile. In business, you either make money or you go under. Now, the first boss I worked for in Congress was a former healthcare provider. He had a great line that he always used. Hey, you don't have to you can stay home and go broke. Okay, you don't have to go to work and lose money. Okay? Poor people have limited resources to pay for their care. The provision of care is a service. It's not the provision of a good like shoes, which all people can afford because we vary quality, right? There are Keds and there are Manolo Blahniks. I got it right, didn't I? Okay. We vary. But the instances in our economy where service is varied on price and quality is done so with the express intent of excluding people with limited resources. The person who cost you $150 to do your hair is not doing $10 cuts on the side, okay? But we're not supposed to vary quality in healthcare the same way, or at least we don't think. So to the affirmative side, I ask you this question, and if I could push you to a 1-minute answer before we go to the audience. How can you make the case that quality healthcare can be provided to the entire poor population with limited resources when the free market pushes you to follow the profit motive without having some level of people going without?
My response to that is that the free market already provides quality in both services and products to poor people because of the profit motive. Dr. Madrigal was talking about all those products. In fact, I would go back 100 years where most wealthy people didn't have a car, certainly didn't have cell phones, and it was entrepreneurs driven by the profit motive that have found ways to lower the cost on those things and improve the quality on them so that even poor people can afford them. And the poor person owning a car today is, that car is going to get better gas mileage, have better safety features than the car a rich person had 100 years ago. So I think the same thing would happen for healthcare if you would start to get the government out of the way. You know, we have done nothing but expand government's role in healthcare over, you know, at least since the 1960s, and I think arguably going back to the 1950s. But, and what has been the result? Well, you know, I mean, 55% quality, regardless of what type of payer system you have. So I really see no reason to think that free markets and the profit motive are in any way inimical to you know, poor people being able to buy you know, needed goods that are low cost and of good quality.
Okay. So to my colleagues here in opposition, okay, I began by making the case that free markets operate with a profit motive. Okay? But I can also make the case that that profit motive drives innovation. Okay? As was discussed, you know, innovation is what comes for dialing up your ability to again, improve a product and charge more for it. I mean, the difference between the iPhone 3 and the iPhone 6, I hope I got that right, and how much you paid for it and as it advanced are significant. But it's driven by the free market and innovation. You take away that motive, what happens next? None of us drive Zeals or Yugos. Look it up, young people. What's your argument that government programs push beyond the absolute minimal quality care necessary to something more like quality maximization in the provision of healthcare services?
I think that's a fair point. And again, I'd like to start by saying I think generally speaking, medical care has been provided because of providers want to do the right thing regardless what the insurance status is. We actually did a study, looked at 30,000 medical visits, found that the length of a visit, that pretty much what happened in a visit didn't matter whether you were uninsured, on Medicaid, or had private insurance. And I think that's because doctors basically say they would like to treat all patients the same way, and they'd like to treat patients well. Now, with respect to the notion of are there ways to improve incentives to improve quality, that's what we're trying, both in the private system and the public system. So the development of things like accountable care organizations, trying to have quality benchmarks that measure both cost and quality, that's happening on both sides at the same time. And so it's a new innovation that we're trying to do. What do the government programs help do? Essentially speaking, they buy access. They buy it so that someone can get to see the doctor, and again, that the doctor can then sort of make a living. So that's the fundamental thing that they do. Hopefully the quality of care that people would provide would be similar no matter what. Hopefully we're finding ways to improve quality both in the public side and the private side.
All right. Thank you very much. All right, folks, it's the moment you've all been waiting for. The opportunity to participate. Remembering again, no filibusters, be nice, or nice-ish. Just, okay. All right, don't be a Republican presidential candidate. All right, let's at least agree with that. Okay. And we'll work around the room. If you would, just stand and identify yourself briefly and ask your question.
Sure. So hi, I'm Nick. I work at the Atlas Network, and thank you guys for speaking with us today. I've got some notes, but I'm just going to toss those aside for a second. I wanted to get to a point that you, Doctor, mentioned very early on in your opening. The idea of paying even just a little bit makes people actually comply with your recommendations and the things you have. Can you elaborate on that more? Because beyond all the systems and the what payer it is and the $690 billion problem, that seems to me to be at the heart of what medicine's all about. Could you really elaborate on that and like this motivation that you have when you pay a little bit?
Well, if you pay nothing for something, it's worth nothing. If you pay something for something, it's worth that. So as you know, if you had to pay for part of your college, you were probably a lot more motivated to do well in college than those people who had mommy and daddy pay for all their college. So the same holds true in medicine. People who have skin in the game, who are actually part of their healthcare, who make it a priority, tend to do much better. And I do have a lot of poor patients that need colonoscopies, and they are expensive, and it's hard to find a way around it. But they will figure out a way to get it. In my experience, anyone who's really needed one has gotten one. I wish it was everybody, but when it comes down to it, they'll figure it out and they'll make it a priority. And that's what I think is really important for everything, be it taking your diabetes medicine, adhering to a proper diet. If you have some feedback on it and it comes out of your pocket and it's worth something to you, you're going to do better at it.
Thank you.
Can I make a response also?
30 seconds, Dr. Cooper.
So I've heard for 30 years now this skin in the game argument. I've never seen a single study or a bit of evidence that suggests that it's true. What we do know is that cost can create barriers. There's very strong evidence of this over and over again. So, you know, if the point is people should be better motivated, people should be better motivated to be good patients to try to take care of themselves regardless of whether they're poor or they're rich. And I think this has something to do with the motivation of the patient and the ability of the provider, the physician, to motivate them to do these things. And so that's the intrinsic part of it. The problem with asking poor patients to pay $10 is if they don't have $10, they can't get it. That's the problem.
Hi, my name is Faith Njoku. I'm coming from the University of California, Irvine, and I just want to thank you for the points you've made so far. But I do have a question, and I'm just going to piggyback off of what you just said about physicians motivating their patients. And you also mentioned earlier that the poor can't pay $13 for treatment if they were to see a physician. I have to respectfully disagree with that. I worked in underserved communities for some time. I also went to school in a very underserved community. And what I noticed was that, you know, and again, we have, who played a sport here again? Can we just raise our hands again? So what I noticed was, you know, the work I did in those communities sort of mirrored how I also took a sport or as an athlete, visualizing something I wanted to see manifest. And when I gave, you know, my students or the people in my community a little more accountability and, you know, respect for value that they can provide for themselves in their community, I noticed something incredible and miraculous. Like, they did take their health into their own hands. But by creating this idea that they can't afford, you know, something as innovative as a free market where they're trying to be successful with a government program, so they're trying to compete with a government program so their prices wouldn't necessarily be too costly, giving them that safety net or that idea that they could not even contribute in that way, I felt sort of hindered their growth and their mindset. So I just wanted to ask you, you know, if you have any experience working in underserved communities, if you've noticed that by telling them that they do have this card and they will have access or a possibility to have access, but by not giving them autonomy to choose where they want to go or to, you know, have a say in the type of care they want, if that hinders the process as well.
Okay, I would say beyond the evidence, I would say my day in, day out clinic visits are determined by exactly what you're saying. So our clinic is on the border of Maryland and DC. DC Medicaid does not require a copay. Maryland does. Most of my patients, a lot of them, who struggle to pay that copay, I have to manage them over the phone. I have to basically outline as much of a visit as I can, help manage them, because they know that at the beginning of the month, when they get that payment to allow them to come and see me, then we can get those things resolved. Whereas I do have far better access to my patients from the DC side on Medicaid. To counter the argument of people who can give are going to value that, I don't disagree. But I've also seen the opposite, where people who have nothing value when you can give them something. When they have nothing to offer, you can give them something. So I understand the point of having somebody take charge. If motivational interviewing was easy, if getting somebody to lose weight, to stop smoking, to take their medications was easy, then we wouldn't require a whole specialty of primary care physicians to make them do it. It would require a phone call, a reminder on an internet EMR message. So it requires a physician to go through those steps, show empathy, and really work through the process with them for them to get motivated to take charge of their health. It's not as simple as the amount of money you're paying on the front end of a visit.
Thank you, Dr. Russell.
Hi, I'm Andrew Widener from McGovern Medical School out of Houston, Texas. Thank you to all the panelists. I have a question for the opposition. It's a two-part question. I want to get your opinion on the study mentioned earlier, the Oregon Medicaid study, which one of its conclusions was that it didn't increase the measurements of health in people who became enrolled. And the second part of the question is, if that's true, to what extent do these social programs act more as a payment mechanism to keep hospitals and providers afloat rather than actually benefiting the recipients?
So I know the Oregon study pretty well. I've been a peer reviewer for some of the articles that have come out from that. I know Kate Baker and Amy Finkelstein, who are the principal investigators, pretty well. So to recap, though, the statement was that they didn't find significant changes in health status over 2 years is basically right. What I will say is they did see improvements in access. So they saw an increase in the extent to which women could get mammograms, that people could get hypertension testing, and so on and so forth. So people were getting more access. I think one of the critical questions and why it's a shame that that study ended after 2 years, it's hard to find progress in some of these health status measures in 1 or 2 years. In many cases, they take a long time. And so would I necessarily have expected to see instantaneous changes? Maybe not. Actually, hemoglobin A1C, they did find fairly close to the margin of statistical significance improvements. Now, this is given the fact that you consider how this experiment was set up. There was a small proportion of patients who were diabetic for whom their A1C measures would have been valid. And so the fact that they could come pretty close to significance, to me, means they needed a larger sample, they needed a little more time. But I think one can ask, do we know that in general providing people medical care necessarily improves their health over 1 or 2 years? And I suspect the answer would be, it's not that quick to change. Yes, it makes improvements. On the other hand, over a global population, are we going to see quick changes? I don't think so.
And just I'll quickly jump in and take a moderator's point here, which is to say that arguably we're in the midst of a similar experiment now between 31 states that chose to expand and 19 that did not. And we'll gain more data with that to see if it is consistent with Oregon. Our affirmative would like a short comment.
I'd just like to say, basically how much time do you need? I mean, if you're not showing, if you find out people have high cholesterol and, problems with their diabetes and so forth, and 2 years later you haven't shown any improvement, I mean, granted it's not same as having 4 or 12 years, but I'll just also point out that, in FDA studies, if your drug doesn't start showing results within 2 years, they pretty much cut you off. So I don't think 2 years is at all an unreasonable or minimal amount of time to show some improvement.
But just okay across the board then. Chronic conditions like diabetes, hypertension, obesity. All 4 of you weigh in. What's your time frame to have shown success, shown progress of any kind? If you're going to raise the question.
I think they should have seen some within within those 2 years.
And do you see with private insurance or with private medical care?
I'm sorry?
Where do you find the evidence that works with private insurance or with private medical care?
Where do you find the evidence that it works with Medicaid? I mean, that's what we were looking at here.
I know. I'm just saying, if your point is you think that the private system works.
No, I don't necessarily think that.
You need to say that there's evidence that shows that you get results there.
I don't think the private system does, because it's not really a free system.
All right. So, all right, enjoyable for a moment here, but I do need to turn back to the barely a moment. Okay. All right, back to the audience, and who's got next? Gentleman there.
Hey, I'm Dan Miliowski. I'm a first-year medical student at Stony Brook University. I was wondering, at what point did you guys come around to your current views? If you were already just kind of liberal or conservative in undergrad, and that sort of just developed as an extension, or if you guys have changed your mind as you've gone through medical school, through residency, and then become an attending physician.
Oh, this is going to be fun. Jump in, either one of you. Who wants this? So when did you grow up? I think is what he's basically asking.
Well, honestly, I'm socially liberal, so I just happen to have this opposite view about or that's called the opposite view about medicine, but I actually think that I have a very progressive view about medicine and think that giving people ownership is not a uber conservative view.
I guess I became more conservative about 3 years ago when I married my wife. She's sitting back there. I know I'm a later. Wow. It was just kind of a long process for me. I mean, I was very liberal when I was 17 and 18, and by the time I was in my late 20s, I was pretty conservative. Where things started to change, I'm just not really sure. I mean, I never had an epiphany or anything. It was just one small little thing after another. So.
Yeah, actually, I might be liberal in Texas and conservative here.
Your knuckles dragged the ground. I missed that part. Okay, next. Oh, I do. All right.
Well, I grew up in Texas too, and my parents were Republicans, but I must admit, for most of my adult life, I've been sort of what I view as moderate, which I'm sad to say these days is considered liberal. There's been a change. But what I will say is, I'm a researcher. By my nature, I am doubtful, and I want to see evidence. And so the things that I've talked about are research that I've done, in many cases research I've seen other people do, where there's some empirical basis.
Dr. Russell.
I agree. I would say my perspective on medicine is it has to work. First of all, you notice all these are all articles. So my opinions are based on the research, is based off the evidence and what ultimately comes out of it. There's not a lot of ideology beyond the fact that I do believe that there's a right to health. However, what that health means and how it translates into policy is different for everybody. But I do agree that someone needs to have the maximum capability of achieving that level of health. So first of all, I went to undergrad at Brigham Young University, as conservative as it comes. Mm-hmm. I went to medical school in Texas, considered a liberal in Texas, but spent some time in Massachusetts and was one of the most conservative people probably there. So coming to DC, I would consider myself among my peers, probably far more conservative, but I fit far more with Dr. Koo in the fact that where the evidence lies is where I stand.
Thank you. Next is there.
Hi, Rebecca Boyer, first-year medical student at GW. So you mentioned that you found a system in Texas that is basically supplemented by the community's generosity in order to provide care to people who can't afford it for themselves. So if that free market health insurance became the status quo, do you think communities where people are overwhelmingly poor would have the same ability to access the care that's supplemented by this community generosity? It's more, just a question about specifically people of color who live in communities that wouldn't be supplemented by surrounding people who can afford to give.
That system is actually in New Jersey. So yes, I absolutely do. I mean, I think if it can work in New Jersey, it can absolutely work anywhere. And yes, I do. I mean, I work a lot with Hispanic population that is fairly poor and doesn't have a lot of extra income, but they do support each other, and the churches also really support people in need. So I absolutely think there are many different avenues that would make that work.
In the back.
Venu Gilapali, as a gastroenterologist who does colonoscopies, I'd like to ask the panel on what basis all of you believe that having access to a colonoscopy, or having access to anything for that matter, is an effective marker for living in good health. We have people in blue zones that don't have the access to care that we do here, and they in general live in great health.
If the gentleman would like to, if you'd like to,
What are the blue zones?
yeah, for
everybody.
The blue zones are areas around
Right.
the world where people have found that people in general live much longer than the average. In some cases, up to 100 years old.
Right.
In Ecuador, Okinawa, the area of Italy, I think one of the places.
yeah.
So we know, and I say this coming from a public health school, that social determinants are the main actual determinants of health. So medical care helps in many areas, helps sustain people. In and of itself is not, the primary determinant of health. Things like your nutrition, your genetics, your physical environment are fundamentally the more important things within people themselves, their own motivations, their education. So medicine is something that helps move people a little further, particularly when there's certain disease crises that are already going on, or when you can sustain things. I mean, this is one of the big benefits of modern medicine, is the ability to help with chronic diseases. So it can help some. Is it the fundamental determinant? I'm with you, it's not.
All right, the next question is here, and we're going to down to our last 3 minutes here.
Hi, Rip Hollister, family medicine, Colorado Springs for 30 years roughly. I've been in private practice, a number of different settings. I've taken Medicaid patients in the past, no longer do. I'm not going to do any name calling or anything, but I will call technical. You talked about Q-Liance, which I consider direct primary care as a free market alternative, simply funded now by some public funding. So it's kind of a mix. And it seems to me that free market collaboration really is the best solution to medical care, even if it does have public funding. So I wonder if you care to comment on the partnership that Q-Liance is.
So I agree that the function and the way that the clinic operates and who they approach as far as employers is more of a free market, kind of more open to whoever they want to choose. But the payer can be any of those three. So in that scenario, you can provide incredibly good care to Medicaid population under that model. So it's a free market approach, but it's a different model as well. So comparing Q-Liance to a standard fee-for-service private practice, you're going to find the DPC model is going to wipe it clean in cost, in health outcomes. So it's a free market clinic. However, the payer is Medicaid through a managed Medicaid provider. So but here's the question. Is it direct primary care then if an employer pays and it's no longer the patient? So it's, if it's a third party paying that, there are a lot of people that would argue that it's no longer direct pay if it's not the patient. So.
No, we have time for one more.
I'm going to take it.
Okay. All right. So the host has
I have the power. Okay. My big concern as I've been studying this, and this is going to be at the opposition because I'm really curious to hear what you have to say on this. We are asking a medical care system to improve health of populations. And yet, when we look at what are the determinants of health, medical care may be 20%, but there's other places that say it's only 10%. So you're trying to leverage, and by changing a way that we treat patients, where really what's causing, what the bigger contributors to health are education, income, and lifestyle choices, which I would make an argument are all poverty issues. And we're trying to solve the problem of poverty through our healthcare system, rather than directly attacking poverty as the primary thing. So why do you feel that, and we know that free markets are what solve poverty. And you can look at that, the metadata across times and across countries, that what has brought billions of people out of poverty, absolute poverty in the world, have been entrepreneurships, global trade, those kinds of things, which markets are associated with markets, not wealth transfer and that kind of stuff. So what are we thinking big enough? Are we actually aiming the direction and our effort in a most effective way?
So do you guys want me to call foul on the host, or are you good to go here? All right, go ahead.
So I'm with you that social determinants are really important. And I wish we could solve problems of poor education, poverty, environmental problems, genetics, et cetera. And so I'm with you, 80% of the way there. The notion that free markets are what have solved the problems of poverty seems to be contrary to the evidence that I've seen, in which, if you ask me, most of the successful countries that have done a pretty good job of reducing poverty, reducing some of those things, actually have a mixed welfare system in which there's combinations of the market and there's combinations of welfare and assistance to help people who don't make it. And that strikes me as both a humane approach and an approach that's feasible. And it is basically the sort of system we have in the US. And to say we need to go all the way one way or all the way the other, I don't think that's what I'm suggesting. I think we could do a better job in reducing the social determinants of health, and I wish we would spend more time trying to figure out how to educate people better, how to reduce some of those underlying problems. Medical care is one part of it. It's not the whole thing. I'm with you 100%.
Dr. Russell, briefly?
I'll be quick. So I think the gains we see in a federally qualified health center is exactly that, is the barriers we see by the social determinants of health are more readily addressed, never overcome completely, but more readily addressed than in a private physician's office who does not have a social worker, does not have a diabetic educator, does not have a coordinator for all our preventative screenings. So that level of care, more comprehensive care, is going to help address some of those things. And that's where I think we get those extra margins, as opposed to a private doc who does really good medicine, but really can't deal with all those other issues.
Right. And to the affirmative side, for just very briefly.
I'll just say that I agree with you 100%, but I guess that's not a surprise. But look, I don't think that these government social programs are really going to be what improve our health or improve poverty. When we started to really expand the welfare state in the 60s, the poverty level really has barely budged since then. And I think that's because government programs create perverse incentives. You can see this in the welfare system with the explosion of for lack of a better term, illegitimacy. We know that there are a few better ways for a woman to get trapped into poverty than to have a child out of wedlock. And I suspect that programs like Medicaid create all sorts of, and with their thousands of price controls, create all sorts of perverse incentives too. I really do think it's free markets that are going to, buttressed by private charity, that you are going to do far more to solve poverty than any government program.
All right. Thank you very much. All right, so we have reached the conclusion of our evening, the conversational point. First, I'd like to ask that you all recognize the thoughtful presentations we've had tonight from both sides, and the intellectual heft they have brought to where we have gone in the conversation tonight. So, first of all, thank you to our colleagues. So now, if in concluding tonight, I can challenge you to take one last moment with us here. All right. So before we began the interactive portion, we asked you all a question, which was, what did you think coming in? Did you think affirmative? Did you think in opposition? Were you undecided? And what do you think now? So I'll ask you, on your honor and in as much as you are comfortable, how many of you all feel like that your position tonight was swayed more to the affirmative?
That's a high.
Yes, like you stand.
Not that you came in.
Not that you came thinking that you changed your opinion. Yes, yeah.
Only if the debate changed your mind. If you went from undecided to affirmative, or if you went from opposition to affirmative.
All right. So did anybody tonight come in thinking they were in the affirmative or undecided and decided they are in opposition? So it seems, just a quick glance around the room, that you all are fairly well stuck in the way you view things. Yes, so I'm glad we at least entertained you for an hour and a half, so that you could think the exact same thing you thought when you walked in. But I do hope that it was at least of value to you and helped you open your mind and watch people actually have civil conversation.
Let's make one more question then.
Yes.
How many learned something that they didn't know before they came in here?
Thank you so very much.
And how many would like to see more of this kind of event? Great. Thank you very much.
All right. Thank you. Good night. Enjoy your evening.